I would like to welcome everyone to the meeting today. This is me, Rabah Abdul, one of the mentors of the MRCOG online sessions, and I'm happy to be with you, my friends. We are starting the activity for the January 2026 exam. We have our WhatsApp group, we have our Telegram group, which is a well-established group more than 5 years ago. We have also our Facebook page. So if you find the activity um, useful to you, my dear friends, or you find any benefit actually of attending, then you are welcome, of course, to join us and follow the activity. My friends, over the last week, I know that you've been revising the guidelines as per the curriculum of the MRCUG Part 2. And I know as well that you find that some difficulty in the answering questions of FGM and for the FGR or small for gestational age. That's why I'm here today. So we used to have a meeting, a weekly meeting, to discuss in a live session, okay, the difficulties or the problems that we faced or the challenges that we faced through the week, okay, in the study group. So here we are starting. This is the first one, okay? So it's very special session to all of you, and I wish you best of luck, my friends, in your preparation for the January exam. I have prepared some questions, me and Dr. Nada, your mentor in the group, on the FGM, aiming to discuss the guideline through these questions and highlight the important point from the exam view. Okay, so let's see. The question number one, this is a lady who had type 1 FGM, currently pregnant in the second trimester. She is requesting cesarean because she's worried about the sight of blood and make her recall the FGM incident. So what would be your action in this case? So if the patient have anxiety, she have flashbacks, she have post-traumatic stress disorder, okay, because of the experience, the horrible experience that she has been going through. So what you will do based on the guideline recommendation? I would like to know your suggested answer, my friends. Yeah, so the patient, yes, the patient will need a referral for psychological assessment, right? And the psychological assessment, will be done for her, will be done by whom? Okay, is it by the psychiatrist first or by the prenatal mental health team first? Will be by the prenatal mental health team, right? So the community-based prenatal mental health team, they are going to see the patient for a psychological assessment, and they might start low intensity, okay, intervention or a high intensity psychological intervention, like in the form of a CBD or one-to-one session, okay. But this is after the assessment. Is this referral is going to be routine or urgent? Of course, I don't have here a reason for urgent referral, so the patient will have a referral routinely, okay? And the same lines of the guideline would say that for the antenatal period, you will offer the patient referral for psychological assessment. And by the way, my friend, here is from the guideline. Okay, by the way, in the FGM, okay, you will find here this very important and useful algorithm in the guideline itself. This is to say that women who have FGM in pregnancy would be started her journey by referral to a designated midwife and or obstetrician with responsibility for FGM. Okay, so they have a proper training, about the FGM, and they can provide her with a good counseling. The patient need also to be in a consultant-led care unit if she is pregnant and she's at risk. The things that need to be done to her, very important, okay? So, number one, this is what we call a recording. Okay, this is the first R to remember. So, data recording. What is a data recording? Data recording, this is to ensure compliance with the HSCIC, okay, which is the responsible authority, okay? Enhanced data set. Document the FGM diagnosis, including the FGM type, using the WHO classification. So the first R is for recording. Now I will have something to be done. What is this? It is reporting, but reporting whom? That's very important, okay? Reporting the patient who have high risk, okay, of having this event again if her baby is a girl or there is another girl at home at risk of this condition. So the child safeguarding risk assessment will be done. By whom? By a midwife or obstetrician. They will use the risk assessment tool. They will explain the law on the FGM. They will report to social service or the police if the unborn child or related child at risk. So I am concerned here in the FGM by whom? I am concerned by the child, okay? I am concerned by the child himself or herself, either unborn or born at home, okay? Then during also the antenatal care, I should have a good plan, right? What is this good plan? So after recording or reporting for those who have high risk to by the risk assessment, the safeguarding risk assessment will be done. Then we will see clinical management plan. Ensure clear documentation and proforma may be used as well, special proforma to people who have FGM. And this is summary of the journey of the woman who had FGM in pregnancy. The journey starts by the antenatal event, right? What I will do in the antenatal event? Antenatally, I will use the professional interpreter if required. That's very important. And don't use family member to communicate with the patient who have FGM, because most likely they are coming from outside the UK. And explain the law of FGM for psychological assessment and screening for hepatitis C, in addition to routine antenatal screening. So here is the point that we're speaking about. In the antenatal, all the women with FGM need psychological assessment after referral, okay? And also an extra test at booking, which is the hepatitis C. Okay, this is in addition to antenatal screening. So this is the point of the referral. It can come to you in the exam as simple as psychological assessment, referral for psychological assessment, or like our question there in the perinatal referral to perinatal mental health team. You got the point, guys? Number 3 is making clinical assessment of FGM. What is the reason of that? Because, my friends, clinical assessment of the FGM, this is what actually be documented, and this is what will come in the questions asking you about the de-infabulation. Okay, so de-infabulation for a woman with FGM, if required, can be done when? Can anybody tell me, my friends? What are the exact time for doing the deempapulation? If required, means that there is narrowing, there is difficulty in examination. Timing for deempapulation. Can I do deempapulation in the antenatal period? Yes or no? Yes, deempapulation can be done during the antenatal if required, as we said. So this would be a planned elective, okay, deempapulation, and this will be done around the 20, yes, 20 weeks. Actually, between 16 to 20 weeks is the best time. Okay, so this is if required. However, if not, then you can plan for the FGM during labor, right? What is the usual time of making FGM during labor? Usual time is at the head crowning, right? Right? This is the usual time. But if there is a difficulty in examination, and this is will come to you in the exam saying that a patient have FGM type 2, type 3, whatever, okay? And this patient, she had narrowing difficulty. By examination, only admit one finger. And she comes in labor now. She comes even she's 3 in labor. How would you take care of her care during labor? Okay. How would you examine to know the cervix, the dilatation, right? It's very difficult, right, to do this. So I need to do the deempapulation early, okay? And in this case, it will be first stage. So first stage is exception if there is difficulty in examination. You got the point? So either 20 weeks, around the 20 weeks, or at the second stage. So this is 20 and second, easy, 2, 2. Okay? When to do the first stage deempapulation? It's an exception if there is narrowing, okay? Or difficulty in examination, makes the examination difficult, the catheterization difficult. So in this case, you go for deempapulation, right? So friends, can I do re-infabulation? Re. So one letter change between de-infabulation and re-infabulation. Can I perform re-infabulation after finishing delivery? No, big no, big no. Whatever the reason, whatever the circumstances, no, 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 no. Okay, I can't really, okay, do this back, right? So it's illegal. Assess other obstetric risk factor and action appropriately. This is for the patient, of course, who's antenatal care, right? So this is the antenatal plan. Intrapartum, important point from the exam point of view, and I can say all exams in the obstetric and gynecology ask the same questions. So, intrapartum, generally managed as high risk for cesarean section, but cesarean section is not routine, okay? Hemorrhage, risk of bleeding as well, and prenatal trauma. Of course, prenatal trauma is high risk because of the previous scar and fibrosis. Some women may be considered low risk. Which woman who had FGM is a low risk? This is an exam question. Look, my friends, if the patient had FGM and she delivered before without any complication at all, means that she had no narrowing. Maybe she have only type 1 or type 2, right? Without narrowing. So for this patient, my friends, who is a low risk and delivered before, what I would do? Just for midwifery led care, okay? if there is history of previous uncomplicated vaginal delivery. Easy, right? And this is an exam question, side of the exam question. Okay? If the de-infabulation is required, ensure that the midwife and obstetrician caring for the woman have received the appropriate training, of course. Number 4, perineal tear in women with FGM should be managed in the same manner as women without FGM. That's an exam question as well. Okay, so every word in this guideline actually is an exam question and came before already. So what is the meaning of that? Meaning that we said re-infabulation is illegal, but what if the patient have a tear? Okay, so if the patient have a tear, like 3rd degree, 4th degree, extended 2nd degree, you will stitch the tear as any other woman. But please don't stitch the cut, okay, that you made in the de-infabulation. So if the woman has a cut and you opened this, right? Okay, and now this is to allow the examination and the blah, blah, blah. Now patient finished the labor. Will you stitch it back to the pre-pregnancy anatomy or to the normal anatomy? My friends in the MRCPI, they are experienced with this question. Of course, I will do to the normal anatomy, not the pre-pregnancy anatomy. Right? Yes, normal anatomy only, like any other patient. Yes, well done. Now we'll come to the postnatal, and the postnatal is very funny. Okay? What is this postnatal, my friends? This is a patient who delivered, finished. Okay? You managed her delivery. Document the maternal history of FGM in the personal health record, child health record, which is the red book in the UK. So there is a book with each child, which is called the red book, right? Which contain information about the mother, father, family condition, and the baby milestones, immunization, everything, right? So if the mother have FGM, this is to be recorded in the baby health record, okay? In the red book. This is for all types of babies, okay? But if the woman delivered the baby girl, why you are concerned? I am concerned because this baby girl, she can go to live with a family that may still believe of FGM. So what I would do? What I will do? Yes, I am afraid, okay? I'm afraid of the risk to this baby girl, and we need to do a risk assessment. Now, am I going to leave all my labor room, all that babies, deliveries, okay, problems in the delivery suite and do the risk assessment? No, okay? Am I going to follow up this patient after she left the hospital? She leave the hospital? No, okay? So what I would do, I will inform somebody else, okay, who is well trained to do the job. How? If the delivery of baby girl, notify the safeguarding midwife, who should inform the GB and health visitor. Safeguarding midwife in your hospital, right? She will inform whom? She will inform the GB and the health visitor. Those are the community people. Those are the people in the same area where this lady live and they know her, right? Patient finished delivery in the hospital, you as an obstetrician inform the safeguarding midwife. The safeguarding midwife will hand over the case to the GB and health visitor because they are in the community. Okay? So they are going to take care of this. They will do the child risk assessment. Health visitor will do the health visiting to the child. And if you know that health visitor job in the UK with any child, okay, will actually continue till the child is at the school age at 5 years. Okay, so means that she will have multiple visits to the family. So she is the best person actually to be informed. Number 3, offer postnatal follow-up if de-infabulation performed intrapartum, or if what? If the planned de-infabulation did not occur because of the delivery by cesarean section. Okay, so now the question in the exam comes, okay? And by the way, this is a scenario in the exam, came already. Patient, she came in labor, right? You were planning to do FGM, right? In labor for this patient. But fetal distress happened. Means that now go for emergency cesarean. Emergency cesarean section is done, but the FGM is not done. Okay? The question here, what you will advise? Perform the FGM before the patient leaving the hospital, or follow up in the postnatal clinic after 6 weeks, or give appointment in the postnatal clinic after 6 weeks to discuss about the FGM, the infabulation. What do you think? What you will do? No, I will not do it in the hospital, of course, after the delivery, right? Patient have cesarean section finished, okay? Because this was an emergency cesarean section, right? Okay, so the patient can come to me in the postnatal and we can discuss it, right? Then finally, he will remind you again, ensure all data required for the HSCIC enhanced data set has been recorded. Well done. Okay. And my question, my friends, here, the data documentation is with anonymization or without anonymization. So means that patient name, okay, and hospital number is written or not? Yes, it must be. Why? To avoid duplication of data. Right? Because if we write without anonymization, yeah, we wrote just a person, just a number, okay? And the patient happen, okay, to come again in another hospital or even in the same hospital, we are going to add another number to the records, right? So every time she come with a delivery, let's say she had 4 kids, she will be in this case recorded as 1 case or 4 cases if we did it with anonymization. 4 cases, yes. So that's why answer is without anonymization, okay? But the patient may be worried about her personal information, that this could be shared, or that this can cause trouble to her or something. No, you will just reassure her, and this is only for documentation, but the data will not be shared without her permission, okay? Clear, everyone? This is an exam question asking with or without anonymization. Okay, so we don't need anonymization, without anonymization. Okay. Okay, so let's back to the question. I hope that we have revised the antenatal care plan of the FGM quickly, okay, and we clear some of the concepts, okay, to make the question discussion easier. Ready, my friends, to the next question? Ready or not? Yeah, that's great. So next question says, a 30-year-old in her first pregnancy in the antenatal clinic at 12 weeks of gestation, she had history of FGM. On examination, she had type 3 FGM and vaginal orifice, admit only 1 finger. When should you have the infabulation? Thank you, my dear friend, Dr. Farhana. So when you will do the DEM population, Dr. Farhana, you tell me, please. I need your opinion. Antenatal, intrapartum. So we said that, especially when it admit only one finger, it's better to be elective, right? Because I know 100% that she will need it in labor, right? So if I do it elective, I will do it during the antenatal period around the 20 weeks and best be between 16 to 20, right? Clear, everyone? If it's not clear, please tell me. Okay. Here, alhamdulillah, a lady presented with her 12-year-old daughter complaining from menorrhagia that started after receiving some treatment. She mentioned that she is leaving for short vacation to one of the countries where the FGM practice is common. She was asking if it's safe to travel with her daughter while you were talking about the consultant advice. You found that she have left the office. What should you do? Okay, so you haven't explained. You didn't have the time to explain. And she left the office. What you will do? Okay, so let's go through the option and try to understand, okay, the rationale behind this. Okay, so my friends, what is the law says, right? The law says that having FGM is illegal. Okay, traveling to do FGM outside the country is illegal, right? Right? But she had the daughter, right? Leaving for short vacation to one of the countries where the FGM is common. So you are still a little bit worried, okay? But you don't know, okay, if that is really a risk to the baby or to the girl or not. What about the views of the family? You didn't do your assessment, means, okay? So the mother is just asking, is it safe or not to travel to that country? So you have to do your job. Can I report this to the police now while the patient have no crime yet? Can I do this? No, no crime to report. So I can't do this. But if I know, by the way, if I know that she's planning to go to do FGM outside the country, yes, I can inform the police to prevent her. But so far, I don't have, okay, a crime. Inform the midwife. No, the midwife has no role, actually. This is for pregnant ladies. Inform the local service, social service, to inquire about the risk assessment, or inform the child protection service, or do nothing. Of course, you can't just choose to do nothing. Okay, so you are now between option C or option D. Okay, okay. So informing the child protection service is similar to what, my friends? Is similar to what? Is similar to the police, right? So protection from whom? Is there is a crime yet? No. Okay, so it will be a stepwise approach since we don't have a clear problem so far, just a patient asking advice, okay? Or asking if it is safe or not. So here we need to go back to the basic. Do you remember what is the basic in any case? Between between yes, there is something called risk assessment, right? Risk assessment of the family, right? Correct. So I wanted to do risk assessment of the family. How to do it? You are not now in a position to go and run after the patient. Who will do this job? Who will do the investigation about this family? Social service. Let's see. Look, my friends, here, this is the FGM, okay, and UK law. This is very important to read, okay? So all healthcare professional must be aware of the Female Genital Mutilation Act, okay? In England, Wales, and Northern Ireland, okay? So FGM is illegal unless a surgical operation or girl, okay, on a girl or a woman, okay, irrespective of her age, right? So it's illegal action, but it can be only done for some people, okay, as a surgery on the genitalia when it is necessary for her physical or mental health, okay? But here we speak about what? We're speaking about surgery, okay? Or she is at any stage of labor or had just given birth for the purpose, okay, connected to labor or birth. So de-infabulation, right? It's okay to do de-infabulation. It is illegal to arrange or assist in arranging for the UK national or UK residents, okay, to be taken out overseas for the purpose of FGM. The purpose here is not in our question there, if you remember, was not clear. It is an offense for those with parental responsibility to fail to protect a girl from risk of FGM. So even the mother, if if she is aware, okay, that her daughter will be taken away by father, for example, or someone in the family, and they will perform FGM, she need to report immediately, right? She can't hide or she can't just do nothing, okay? If FGM is confirmed in a girl under 18, okay, either on examination or because the patient or parent says it has been done, reporting it to the police is mandatory. And this must be within 1 month of the confirmation, okay? So once you have police, okay, once you have FGM, you have to inform the police, but within 1 month, okay? Female genital cosmetic surgery, okay? This is may be prohibited unless it's necessary for the patient physical or mental health, okay? Re-infabulation is illegal here. No clinical justification for re-infabulation and should not be undertaken under any circumstances. Okay, and this is a question in the exam. They will tell you that a woman is distressed and she wants re-infabulation back. No. Affecting her quality of life? No. Affecting her mental health? No. Under any circumstances? No. Okay, so re-infabulation equal no. FGM is illegal in England, right? Wales and Northern Ireland. So here in the Act, again, it is illegal to excise, infibulate, or otherwise mutilate the whole or any part of personal genitalia, including the major labia or the minor labia or clitoris, or to aid, abet, or counsel, or procedure the performance by another person. To aid, abet, counsel, or procure person to excise, infabulate, or otherwise mutilate. Okay, so this is exactly the FGM Act. But here, in the Serious Crime Act, this is the 2015. It reinforces the existing FGM legalization and introduced mandatory reporting of FGM in girls under 18. By whom? By healthcare worker, teacher, and social worker to the police. Okay, so whenever you have a girl under 18 with FGM, remember the here she had FGM already. The action will be what? Reporting to whom? Under 18 and FGM equal? Police. Yes. Yes. Okay. So here, my friends, in the reporting one, in the reporting means making a referral to the police or social service and guidance from the Department of Health. Okay? The requirement to report depends on whether an adult or a child is affected. Let me change the color here. FGM or a child considered to be at risk of FGM must be reported if necessary without the consent of the parent. Okay? And the information should be shared with the general practitioner, the GP, and health visitor. Okay? There is no requirement to report a non-pregnant adult woman aged 18 or over to the police or social service unless a related child is at risk. Okay? Remember that the patient right to confidentiality must be respected. Okay? If they don't wish to take any action, and no reports to social care or social or police should be made in these cases. This is for whom? Which age? 18 or above. Okay? So we are concerned again by those who are below 18 because those are the children that need our protection. The reporting will be either police or social service. Clear, my friend? If the crime not happened yet, where you will go? Which person you will seek help? Or which authority you will seek help from? No crime yet, it will be social service. In the whole guideline, there is no child protection, right? Child protection comes in another situation, right? So the whole guideline speaking about the social service, social service, social service can do child protection, right? But when, okay, we find the case at risk or not, okay? So the social worker's first job is to assess the risk and then protect if needed. You get the point, guys? Okay, social service, my dear friends, they have, by the way, they have a wide connection and they have wide authorities as well, and they are cooperating their work with the police. Okay, so don't just underestimate the social service job. Okay, they can do a lot. Okay, so they can visit the family, they can investigate, they can offer mental support, psychological support, financial support, legal support, bring the police, everything. Okay, so they can do a lot. Okay, so social services here in this case. Here, 22-year-old Sudani asylum, sorry. I'm sorry, guys, I just clicked wrong slide here. Okay, 22-year-old Sudani asylum seeker is seen for booking in antenatal clinic at 12 weeks. She is primary and an ultrasound scan revealed singleton pregnancy. She had history of FGM. On examination revealed it was type 2. Vaginal examination was done without difficulties. What would you do, or what would be the appropriate action? So you guys tell me, okay? This is a low risk or high risk? She is still primary, right? Okay. But on examination, no problem, right? Okay. She's still primary. She did not have a delivery before. Okay? So, but examination was good, done without difficulties. So here, what I will do, no plan for deinfabulation. I will not plan for deinfabulation during labor, either in the first stage or in the second stage, since it's no problem for me. Elective cesarean at 38? No, why? Elective deinfabulation, why? There is no problem, since I have done examination without problem, and it was only type 2. Okay, episiotomy only if required. Okay, so the answer will be the episiotomy only if required in this case. 17-year-old girl attended a gynecology outpatient with complaint of irregular period. She migrated to the UK with her family a year back and gives history of female genital mutilation. As a doctor practicing in the UK, which of the following is an appropriate action? Yes, of course. Okay, so the answer will be inform the police. Okay, right. I'm sorry, guys. There is something wrong. It's like crazy in this Zoom today. Okay, so inform the police. Okay, why? Because she had the genital mutilation done. Okay, and she is under 18. Okay, this will be reporting within 1 month, okay, of the event, correct? This is another patient, 19-year-old, attend the gynecology with complaint of irregular period. She gives history of female genital mutilation. As a doctor practicing in the UK, which of the following is an appropriate action for you as a gynecologist? Yes, well done. Okay. I don't need to inform the police in this case. Why? She's 19. And when the patient is 19, what I will do? I will respect her confidentiality. Okay. So confidentiality is here. Okay. Is a must. And you respect the confidentiality and the patient right not to report. Yes, exactly. So treat her for irregular period only as this is the primary complaint, right? Clear, everyone? So answer is D. Patient with personal history of FGM delivered the baby boy. What would you advise before discharge? What's your advice? Document maternal history of FGM in the baby book, inform safeguarding midwife, inform health visitor and GB, or discharge as no risk. So you might think that this is a boy, no risk, but actually the guideline didn't say that. And the practice in the UK did not say that also. So they would tell all the information required, okay? They will tick actually the boxes, okay? And if there is FGM, this is must be done, so the GP and the health visitor will be aware. Okay, so yes, exactly, well done. A, document maternal history of FGM in the baby book. And this is the algorithm that I used for explanation from the guideline, okay? And next, this is a patient with personal history of FGM, delivered the baby girl. So what would you advise before discharge? Yes. So well done. Inform the safeguarding midwife. I'm so happy that nobody chose to see. Yes, well done. So first you inform the midwife, and the midwife by turn, she will inform the health visitor and GP. Well done. You are on call today, and 20-year-old patient presented with a cut in the genitalia. She insisted that this is a result of falling down while taking a shower. What you will do? Yes, yes, well done, everyone. So only treat the wound and respect the patient right not to report it. Yes, well done, everyone. So I can see that you are doing very well with the FGM guideline. Yeah, and I think we came to the end of the discussion of the FGM, everyone. We still have rest of the session, okay, and this will be question and answer on the SGA and FGR guideline. Okay, my friend, thank you very much. I will ask you for a break and then we'll come back for the second round of this session. Thank you. Oh, thank you very much, Dr. Farhana. This is so nice of you, my dear.